panel for this panel discussion with the topic ethics and AI in healthcare. Before we dive straight into the actual discussion itself, let me just do a very quick introduction of our panelists. So if you can see, if you can see the PDF that I just shared, joining us today, we have Dr. Jasmine Ong, Associate Prof Dean Ho, as well as Associate Prof Daniel Ting. Let me just do a quick introduction, and feel free to intro yourself as well later if I miss out any information. So Dr. Jasmine is actually a clinical pharmacist specializing in clinical care. So her research interest, right, actually lies in the translational pharmacokinetic and application of artificial intelligence in medication safety. So in her free time, she actually daydreams about how AI and robotics will eventually take over the world. So as for Prof Dean, he is actually the Provost Chair Professor in the Department of Biomedical Engineering and Pharmacology, Director of N1 Institute of Health, as well as the Institute for Digital Medicine, my bad. And he is also the head of department for biomedical engineering. So on top of all this, right, he's actually also the co-founder of KYAN Therapeutics, and his discovery have actually been featured on CNN, The Economist, Forbes, Washington Post, NPR, and other international news outlets. So actually, all this is like we done our own research lah. Actually didn't ask us to speak all this. Yeah. So and lastly, we have Dr. Daniel Ting joining us as well. He is the director of Sing Health AI program, head of AI and digital innovation at Sing Health Eye Research Institute, and he is also the assistant professor in both Duke NUS Medical School and NUS Biomedical Engineering. So to date, he has published more than 180 peer-reviewed papers, book chapters, conference abstracts, including more than 40 AI and digital technology articles. So this is just a brief introduction of our panelists for tonight. Clearly you can tell that I was reading off a script, but yeah, to make things slightly more interactive and casual as well, perhaps we can kickstart with how Dr. Daniel, how do you actually know or rather have met Prof Dean and Dr. Jasmine? Yeah.
Oh, wonderful journey. Yeah, I mean, just a small correction for Professor Dean Ho. He's a full professor and the chair of the biomedical engineering.
It's all good, man. It's all good, dude. It's all good, dude.
So that we
totally fine.
Deny the admission next time too.
No, it's all good.
I'm just kidding with you. Yeah.
Apologies on
Thanks
our
very
side.
much. Thank you very much for the kind invitation. I thought I'd just do a very small icebreaker so that we can kind of get eased into the discussion. Yeah. Oh well, I mean, Dean and Dean, how long have we met? About half a year or so.
Half a year.
Yeah, half a year.
A lot has happened.
Yeah, that's right. And Jasmine, same thing, right? About half a year or so.
Yeah, about half a year.
Yeah.
Oh wow, that's actually quite a short time. I thought you have been longer. Yeah.
Oh yeah.
That's how awesome this ecosystem is. Everybody gets to know each other and do cool things together, and things happen fast.
Exactly right. Yeah, exactly right. Yeah. So I mean, what has linked us up, I think, is the tech and innovation. Yeah. So absolutely. Dean and Jasmine. So what do you guys think?
That's it. It's everybody's close by, easy to connect with everybody, and cool things happen.
Yeah.
Absolutely. I think it's a very supportive environment as well. So when people of like-minded people come together, sparks fly.
Yeah. And in fact, when Jasmine and when I actually first heard about Jasmine wanting to do the AI and tech, I was like, wow. I mean, and in fact, we are at the right forum right now, right? I mean, all of you are probably all juniors to Jasmine, and we were just chatting before the session started, and hopefully some of you can get really inspired by her, and and then come and join our circle. And Dean, so Dean, I don't think he needs further introduction. I hope like you guys have read up like how.
No, it's all good, man.
The world superstar, man, guys. Like and farm science students. I just got told about this farm science course. Please, drug discovery. He's the best guy. Well, not in Singapore only, but also one of the best in the world. Yeah. So. Over to you, Dean.
That's thanks for embarrassing, man. Our team is comprised of just amazing people, and that's enabled by this community. We're able to do what we do because of this ecosystem and how quickly we can build bridges. And so I think one of the coolest parts about this event is that it's student driven, right? And I think that shows us the cool things that students can do early on in their careers to accelerate their ability to change the way that their fields are practiced. And so that's why I'm excited to be here. And congratulations to all the students for an amazing event.
Yeah, thanks for your kind words. Actually, this is exactly the why, like, the team behind this like running this hackathon, because we feel like, at the end of the day, we are not seeing as much student-driven innovation as we want to be. And I think this will really be a good start for all those aspiring entrepreneurs as well. Yeah. So actually, in recent years, we keep hearing all these buzzwords, like AI, machine learning, deep tech, big data analytics. So I guess in a more casual context, in a more Singapore context, how would you describe the integration of AI or big data analytics in that matter in the local healthcare scene? Yeah.
Dean, you want to go first?
I'll go quick, well, as quick as I can. So hopefully I won't take an hour. So no, I'm just kidding. So, I think that so I would say, given that we have a lot of students in the audience, I think what's really important to note is that Singapore and the region is at a place right now where it can do things in a uniquely Singapore-driven strategy, right? I think that what I mean by that is when any field emerges, right, there's a quick move to establish and define what all the terms mean, AI, big data, et cetera, et cetera. But I think to really allow these terminologies and these opportunities to really come to fruition and to really change the way that healthcare is practiced, it takes a lot more than technology, right? And so what I see right now is in the early stages of a technology, it's the buzzwords fly. But what really will be the difference between real impact and kind of this burst of a bubble is the ecosystem that supports this technology. And what I mean by that is AI for healthcare, right? What is that? It's better ways to diagnose, like the amazing work that Dan and the team at SERI, SNEC are doing with regards to diagnostics, community health, et cetera. And it also includes therapeutics, right? And so we do a lot of therapeutics work, but it's not just developing new therapeutics. It's working with amazing doctors, nurses, pharmacists, and beyond, and then healthcare economists, and then behavioral scientists, and then the payer community to see these approaches through. And the thing is, you can only really work with them if they are accessible, right? And if they're able to engage in these collaborations, and that's what we have here, right? So in my opinion, AI in healthcare is a way to, accelerate and optimize better diagnostics, better therapeutics, but above all, making sure that it's accessible, right? That these approaches are accessible, and that the AI, in addition to reconciling data into action, is ensuring that the way that that data is collected is supporting the optimization of that outcome, right? Because converting data into action and converting data into optimized action can be very, very different. It can mean the difference between hundreds of thousands of lives saved. It can be the difference in hundreds of millions or billions or even more dollars saved in healthcare costs, right? And it could be very well mean the preservation of certain healthcare systems or not, right? And so I think that we are in an ideal ecosystem to do all of that. But it takes an entire community working closely together.
Wow.
Less than an hour. That's
really
That's the true miracle.
Oh wow. Yeah, actually, just to zoom in specifically when you mentioned, on our patients and clinical practice, I just recall this conversation I had with Dr. Zubin previously as well in another panel discussion, right? I think at the end of the day, we are like really thinking, how can we really adopt adopt tech, in healthcare without really replacing, the core of it, which is our patient, which is, our medication safety. And I think on this note, I just want to ask, for Dr. Jasmine, because in your bio you mentioned, about how you see AI coming in to really assist in the medication safety aspect. So like, just want to hear your thoughts on this as well. Yeah.
So perhaps just to start off, I sometimes think about the future. I think about, in 30 years time, 40 years time, 50 years time, when I myself require healthcare, what do I foresee the scene to be like? And to be very fair, to be very honest, I don't foresee a hospital which is attended to by just robots and virtual assistants and softwares running at the back end office, telling me what is my diagnosis, and telling me what drugs I should be taking. I do actually foresee some kind of like a very a very integrated environment whereby AI and technology actually comes hand in hand with the human, like the physicians, your healthcare professionals, your nurses, providing the human touch to kind of augment the entire healthcare ecosystem. So I think it's very important not to forget that at the very end of the day, your technology and your AI can only do as good as what a healthcare professional can do, and we all need that human touch still. So I think if you ask me, I think that's really what I foresee and envision the future to be like.
Yeah. So for Dr. Daniel, anything to add on after such elaborate explanation by both Prof Dean and Dr. Jasmine? Yeah.
No, they've spoken everything that I wanted to do to say, and they actually hit all the points at the right spot. And I just have a very like what Jasmine said, right? I mean, I can't agree more. I just wanted to echo what she just said, right? Human would at least right, if I were to predict in our lifetime, I don't think it will be replaced by robots or AI, right? But we would be smarter, we can be augmented, and we can be assisted, right? And and uh, when I first started doing this, right, I just wanted to share my experience. I got nothing to add. I mean, all their points is right. I just want to share some of my experience in the past. 7 years ago when I started doing this, everyone was asking me, "Why are you doing this? Like, are you trying to like get rid of us? And what are you trying to do?" Right? I mean, um, and we a lot of people asking me these questions were the people I feel is in a rather privileged environment, right? So let's see the world as a whole, right? You can actually potentially divide the world into the more privileged ones, which is what the developed countries, where we're at sitting right now, and you can also have the slightly less privileged population, right? That we actually don't really come into contact very often. Places like Africa, right? Zambia, I actually did a study in there. You can actually look at a lot of different countries, rural places in China, right? I mean, those are the uh, those are the area where the healthcare expertise is severely lacking, right? How can we breach this? Using some of the cool things that the first world is doing, and then trying to deploy it in the developing countries. This one of the severe unmet need right now, right? You can see it has been actually amplified by the impact of COVID, right? Right now, we were severely hit by COVID worldwide, right?
Yeah.
People are dying, people have no access to healthcare, people are denied from the doorsteps because of the social distancing measures and stuff, right? So how could we actually harness, AI, digital tech, not just to help our own country population, but how do we reach out to, the developing world population? This is something that I want everyone to actually just take a pause and think a little, right? I mean, of course, we can always talk about cool stuff. Yeah, I mean, I'm doing this, I'm publish these papers here and there. But truly, what have you actually changed somebody's life? I mean, this is something that I'm constantly thinking about, and this is something that I constantly think I can do better, right? I mean, I just wanted to inject, since we are talking about AI ethics and a bit more humanized stuff today, is the less hardcore stuff. I just wanted to put all these things into context so that we can actually get our conversation started later. Yeah, I mean, this is something that something else that I will also want to add on. Yeah.
Yeah, I mean, totally agree. Actually, this brings me to I think one of the questions that at least me, I'm not sure if most people have this question, is in terms of healthcare, for all the healthcare professionals, be it clinicians, pharmacists, or nurses in that matter, there is, points or situations whereby we need to make clinical judgment. So I think just to throw the question out there, how do you foresee, AI assisting our healthcare professionals in making such decisions? I mean, especially in the context whereby, I think some might propose, what if, we let AI to make the decisions and judgments, and we are losing the whole human touch of it, and how can we then justify that the right decision was being made? Yeah.
We should ask Jasmine about that. She seems to have very, very, strong, comments about that just now. let Jasmine.
I would like to argue that despite having AI on board to actually assist us in making decisions and clinical decisions, I would like to challenge all out there that, in fact, you will need to be even more grounded in your clinical knowledge, your clinical reasoning, to be able to actually integrate that recommendation that is provided by the AI and decide for yourself if, at the end of the day, this is what you are going to apply to your patient. Because I think one thing that is very important for us is accountability, right? So we ourselves, actually, as professionals, we need to be accountable for the patient's health. And yes, of course, you can use all these assistive tools, all these AI algorithms to help you make that decision, to highlight certain things that were not apparent to you with your bare eyes. But at the end of the day, you need to remember that we need to be responsible for our patient's health. So we need to, in fact, be even more attuned and to be even more informed of, to be even more informed of, how that AI algorithm works before we can actually make that clinical decision for the patients.
Yeah. I was going to add, that's a great point. And, I'll add further that I think the role of all clinicians, right? And we talk about clinicians, allied health, so pharmacy, nursing, doctors, and beyond, in determining how the data is collected, right? So Dan and I did a grand rounds last week where, there's a debate of how much data do you need, right, to make a decision. But we argue it's not how much data you have, it's how it's acquired, right? And so when we talk about clinical decision, I'll give a specific use case and then talk about how critical it is to have the clinical community engage with that, right? And so, we actually had a case about a couple months ago where we had a stage 4 advanced solid cancer patient who was on a second line combination regimen, and wasn't responding at all, right? They get the dose, they get the regimen, not responding. And it's common, right? It happens all the time. And then you move them to another line until you run out of options, at which point you either go hospice or you find a clinical trial. And the way that we approach this patient is different. The patient, we don't just give them a standard clinical dose and then see if it works or it doesn't work. The way we calibrate each patient is we have protocols allowing us to expose the patient to different doses that are all within range, allowable range, but we also make sure to measure their response at these different doses. So we're actually calibrating their interaction with this drug. And we had evidence that this patient could respond to a lower dose, even though they were not responding at all to the standard clinical high dose. And so the protocol allows us to drop the dose back down, right? So standard dose, no response, drop the dose back down, and within 1 week, their biomarkers flipped. Right, they flipped from totally increasing and to immediately decreasing, and subsequent imaging confirmed stable disease, right? And so in terms of supporting clinicians' decisions, this is a process that is empowered by the clinician's own abilities and willingness to acquire data in a way that makes sense, right? And so what we did not do in this case is, aggregate 1 million patients worth of data, feed it into an equation, and have the equation spit an answer out, right? That the clinicians will just follow, right? It's actually an engaged process whereby the clinicians are fully involved in how the data is acquired. They're able to see the outcomes. They're able to understand how the answer was derived, and then ultimately make the decision, yes or no, do we try this dose or not? Right, which I think is the ultimate partnership between data that's acquired correctly, right? Which is, by the way, a very small amount of data in this case. For some instances, certainly for diagnostics, you need a lot of data, right? For intervention, if you want to optimize the intervention, there's actually different ways to acquire the data. And sometimes it's really a small amount of data. But it's a closed loop in the sense that the clinicians help acquire it, and then the clinicians help decide. The final thing I'll say is it doesn't even just stop there, right? We've had cases where we recommend a lower dose, and the pharmacy actually chimes back in and says, okay, so these are the different ways in which we can deploy this type of dosing, right? And sometimes, you know, if we recommend 50 milligrams, all right, the clinician or the pharmacist can come back and say, hey, look, if it's 50 milligrams, you need 5 tiny tablets, okay, to get that type of dose. But if you give 60 milligrams, it's 2 tablets, right? Or, you know, or less, right? And so these are things that I think when we think about the practicality of deploying AI-assisted intervention, there's a lot of pieces there that involve the entire community that have to be discussed, right? And that was enlightening for us because, you know, when it becomes too difficult to take 5 pills, 10 pills every day, the AI is only as useful as the patients who actually abide by the recommendations and the doctors that follow that, right? And so, first of all, I think certainly the clinical, the healthcare community as a whole will be deeply involved, right, in the process of not only making the decisions of what to do, but helping to acquire the very data that will enable them to make the judgments.
Yeah, I totally agree with what you say. I think like in a sense that, you know, from bouncing off Dr. Jasmine's point as well, I think with such tools, like, I mean, the last thing we want to do is to be even more complacent, but instead, I think with, you know, there's always the cliche saying, with greater power come greater responsibility. Yeah. So I think, yeah, I totally agree with, you know, everything that has been said so far. Dr. Daniel, have anything to add on? Yeah.
Don't ask me that question. Usually you'll come with a half an hour spiel. Dean usually go for an hour. I usually go for
Understand.
No.
So actually on this note then, actually it kind of reminded me of Curate AI as well, in a sense that instead of using a mass aggregate data from random sources or like all in the past, all the past data, I read up and it kind of says that, you know, there's some sort of testings that is being involved. So I just have this question. I think it's a personal question. It's more like how then can we apply such a method, right? For conditions or diseases that are like, you know, slightly more long term, and we can't really have the immediate responses, like the data that is like, you know, more readily available. Yeah, I mean,
yeah, I would actually argue it's better for the longer term diseases, right? Because Curate is designed to sustain the optimization of treatment, and you actually need the longitudinal data that's available. For some things like cancer, the data that you get is quite actionable, right? Like a PSA reading, which we've done before, maybe CEA, certain markers that are available. But for things like blood pressure, for things like transplant immunosuppression, management of diabetes medication, and then the thing we're doing now, which is cognitive training, right? Where we're using, instead of pills, we're using software as the intervention, right? The gaming is the treatment. Curate is dynamically modulating the intensity of the training, analogous to the dosing of the medication. It's actually better for longer term treatment because the evolution of how the patient responds is much more apparent over time, right? And so for us, we are agnostic. We do care though, right? If we're about to treat somebody for cancer, we ask the doctors, if you give them this dose, how long will it take to see a response that is attributable to that dose that they got? Sometimes it's 1 week, sometimes it's 6 weeks, sometimes it may be 6 weeks, but we'll add a little extra imaging or blood draw in between it. It's actually faster than we think, right? That in and of itself, the response time is individualized, right? But for things like cognitive training, hypertension management, this is a sustained and chronic process that we address. So I'd argue that it's even better. Now, again, the sustained workflow includes the need for the diagnostic side. What is the diagnostic we're going to use to guide this treatment, right? It certainly involves the pharmacy side when we're dealing with therapeutics, because it is a partnership between how we optimally decide what to give and how we deliver that. There's pharmacoeconomics involved, right? There's logistics involved to make sure the patient has an easy way of adhering to what's recommended. It's way beyond just the cure rate.
Yeah, I
Understand.
think I can't agree more, right, Dean? I think this is something that I would love to have some say, if I may.
Please.
Yeah.
Go ahead. Go ahead. Yeah.
No, I think this is something that once you get into the behavior, right? I mean, we're talking about behavior. You use this term a few times. I really love this term. I mean, when we talk about AI, it's just a tool, right? I mean, today. So, I mean, having changed someone's, the behavior actually can be very sustainable, right? For instance, like how do you actually I mean, it's actually easier said than done, right? I mean, just taking myself for example, I for the last 1 month I wanted to go to gym, like spend 1 to 2 hours. Dean knows that. That is true. I'm not faking this up. Yeah, I mean, I think it's quite sustainable for the first week. The second week, COVID, phase two got back, and how do we actually maintain these habits or the behaviors when there's some unanticipated event is happening, right? I mean, that is just one of the examples um when like a couple staying at home, looking after each other, one fall ill, and the one falling ill is supposed to instill the medication for the patient. How when I mean the medicine always did not take this into regards. We always say, oh yeah, you have these, we look at biomarkers and then we adjust our treatment. But how do we actually go around the ecosystem? You talk about AI integration. So I just wanted to take ourselves to a larger ecosystem as well, to say, hey, I mean, what about the support, the social support at home? How do we change, how do we actually change behaviors based on what the psychosocial support a patient has? I mean, I think this is a very interesting topic, and I'm sure Jasmine see a lot of patients who because you see, like, okay, talking about my own specialty, ophthalmology, right? Eye drops is how small, right? When you want to drop the eye drops, we are seeing visually impaired patient and we ask them to instill something, the eye drops is good for their visual impairment. So in a lot of ways, the things that is affecting them is impacting the way that they should be using their medication. How do we actually take all this into account when we use AI and other diagnostics, to help with our delivery of care? And this is something big, and this is something that I think, Jasmine, probably you want to also kind of share some of your experience on that as well. Yeah.
Yeah, okay. First, I want to say I'm a secret fan of Prof Dean Ho's work. So one
Oh,
of the
there you go.
one of the very first papers that I read that kind of spiked my interest in AI was actually one of his Curate AI papers on titrating tacrolimus in a liver transplant patient. Oh my goodness, that was an eye opener. In
Dean,
my
we're all your
mind,
big fans, Dean.
absolutely. In my mind, I was still thinking about pharmacokinetic principles. I was thinking about pharmacogenomics, and I was racking my brain. How can I put all these into practice and be able to accurately predict a drug level for a patient, especially when it's in the realm of immunosuppressants. It's all the more important. And I thought that was a very interesting approach, and I do believe that would change the face of how we dose medications in patients in future. And I do agree with what Prof Dean and Dr. Daniel has mentioned about sustainability. So I think at the end of the day, we just need to be able to be very creative with the way we deliver our work and deliver our interventions. So yes, AI can only do that much, but hey, can AI actually assist patients in improving medication adherence? For example, currently a lot of people are wearing Fitbits, health trackers. Can that actually also be used as a tool to actually improve medication adherence? Yeah, so I think there's a lot of room for us to be creative and think out of the box.
Yeah,
Yep.
just to tap on what Jasmine has said, right? I mean, can we even actually input the number of steps into somebody's the daily physical activity into, say, to modifying the antihypertensive medication, for instance, right?
Yeah,
Just to put
absolutely.
this out there. I don't think anyone's doing that now. 5-10 years later, can we do it? I'm not sure. So those are some of the things that I feel as the next generations, or even next generation, like you guys should really think about, right? How do we actually incorporate some of the different stuff, right? Not just the conventional medicine that we have learned for the last 100 years, but we're talking about future. I like what Jasmine said. Future, what is future? I'm not sure, right? I mean, this is something that Dean and I always talk about, right? Just imagine the healthcare in 10 years, 15 or 20 years later, when we get older, when we go into the hospital, what are we anticipating? I'm not sure. Big questions, but interesting to think about. Yeah.
Well, I was
Yeah.
going to add, what I'm so fortunate, what I consider, to be amazing about this ecosystem is the discussions that we're even having right now, right, with Dr. Jasmine, Dr. Dan, because, when we think about training our future clinicians and future engineers, I think by and large globally, the intersection of engineering and medicine is very widely championed, right? But I think that, just earlier today, I made this notion that when you look at the COVID pandemic, things that used to take years have taken less than a year, have taken months. And so we've already proven that amazing things can be done in a much shorter amount of time. But so to me, this makes me realize that I think engineering and medicine is like breathing, right? Like that's already kind of step one that has to happen. But what steps 2, 3, 4, 5, 6, 7, 8, 9, 10? It's really sitting down with pharmacy, with clinicians, with nursing, with payer, with economists, with behavioral scientists, to really tackle challenging things that maybe can be solved more easily if we get into more deep dialogue regarding the expertise in each of these domains that, when connected, can be truly catalytic, right, to redefining healthcare. I'll give an example that we've got this great team of behavioral scientists at the Institute for Digital Medicine, and they're running a study right now interviewing doctors, nurses, caregivers, expanding to pharmacists and beyond, to understand how is it that we can actually make all of their lives easier with AI and digital, because it's not always going to make it easier, right? There are many instances where technology will become a pain point, but we would like to understand that now versus later, right? And I think what's amazing about the SERI team and the SNEC team is that a lot of these factors were considered very early, right? Which allowed some of these really cool technologies to be deployed, right? Ideation and deployment are as far apart as you can imagine, right? And so it takes engineering medicine, step one of many different step ones, right? Real addressing of challenges that will be encountered when integration, implementation, deployment are confronted. That's the true catalyst, overcoming those barriers. So I'm the lucky one. I'm just glad to be here. Great community to be a part of. It's amazing.
You just want to ask for another drink, man. I know it. I can see it.
There you go. There you go.
Yeah.
I think one big question that we all always have is about, like what Prof Dean said, like there's a difference between ideation and implementation. And I think in especially in the Singapore context, some of our, I see the Q&A tab, we have some questions from Zoom as well. I think we are just curious as to how we can actually deploy and implement such, solutions in the healthcare system. And let me just show one of the question on stage. This question is from Zoom. How equipped is actually Singapore's regulatory environment at present to handle the use of AI in healthcare?
I can share a little more
Go
about
for
this.
it. You go first. I'll follow.
Okay. Well, I think we are still learning, right? I mean, so as US, UK, Europe, this is something really new, right? If you look at the first, I mean, AI is nothing new. I mean, just to state this, right? It started 1950s, but what's the new kids in the block is deep learning, right? I mean, that started back in 2010, so 11 years on. And the first paper in the field is in 2016, right? Deep learning based retina imaging from Google's team, right? And subsequently our team did something similar, and I would say the last 5 years, if I were to describe the era, is the tsunami, right, of deep learning papers, right? Dean sits in the editorial, I mean, he's the chief editor in a journal, and I've seen a few editorial boards, and we see a lot of these coming, right? Flooding, in fact I will use the word flooding. And the government, US FDA, first guidelines to regulate SAMD, software as a medical device, right? I mean, for those of you who are interested, go read up, published in 2018, right? And this is the time when all the regulatory body is trying to think really hard how to first regulate the use of deep learning system within the healthcare space. Second is, how can we even start creating a Medicare billing code, right? To actually, for someone who actually, if you were to use something in the healthcare, someone has to pay for it, right? So I mean, those are the another big areas that we can spend I mean, days to actually talk about this. And thirdly is that how is Singapore compared against the other countries right now. I mean, I can share some of the larger initiative, some of which Dean is actually in, and Dean is in some WHO, which he can share later as well. But for MOH perspective, we are actually setting up different task forces, looking at how we can regulate AI, and doing the AI guidelines to actually guide the physicians, the healthcare practitioners, scientists to actually do, to build like the deep learning system that is in compliance with the regulatory approval. The HSA is our Singapore regulatory body, and they are also similarly really helpful. I mean, I can share that personally. We have got the approval to actually deploy deep learning system in automatically detecting the patients who needs to see us, the retina specialists with advanced form of diabetic eye diseases, right? So this is something that we worked really closely with HSA a few years ago, and get it approved, deployed, and then subsequently we went to European CE mark, and now it's been licensed to more than 20 countries worldwide. So I mean, those are the things that I think we are actually ready. I mean, in Singapore, but of course, there's much more to learn. Yeah, Dean, I'm not sure what do you think?
I was going to add that I've had a chance to interact with regulatory agencies from worldwide. As Dan mentioned, I'm on the WHO working group for AI for health, specifically as it pertains to regulatory considerations. It's been a privilege working with a global community, and we meet regularly, and we're about to, we're drafting our recommendations and things like that. And I would say that Singapore, I think the question is how equipped is our regulatory environment, and I would say it's very equipped. In fact, I would say that the ability for the ability for the ecosystem here to adapt, to be agile, is exemplary, right? It's amazing, and I'll give specific examples of this, right? Within my first maybe 6 months of being here, we were contacted by a patient who needed help, was not responsive to therapy, was being warded after just any dose of anything. And we met with the doctor, we met, with the clinical team, and we had decided that we would try to initiate a trial designed only for that patient. And it was complex, right? Because there's medical board, ethics board, imaging, the number of images a couple extra ones that were needed. This involved multi-campus. We contacted regulators, research office, legal office, finance office. I mean, you just think about every office you add, how much more time it could take to get this done. And we got the whole thing done in 2 weeks, right? And that example is going to become like a case study, actually, in how proper and streamlined engagement can lead to life-saving outcomes, right? And we've had the privilege to sit with the amazing team at HSA. And when we talk about things like N of one healthcare, right, we're not just meaning, hey, let's just only treat one person forever, right? It's how can we make truly personalized healthcare more accessible to all, and how do we regulate to understand if it is indeed working, right? And it takes a really deep dive, right? So we have these meetings with HSA where we're showing them our data, but we're going all the way down to the statistics, right? The trial design, the statistics. And when everybody's getting a different regimen from each other, you have to start thinking about different ways of analyzing the statistics of really whether something works or not. So instead of just asking for p-value, 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 it's looking at variance analysis between the treatment arm and the control arm, and how many patients do you really need, right? And Dr. Jasmine mentioned the transplant paper. In the beginning of that trial, in the studies, the reviewers were like, what's your p-value? What's your p-value? And we're like, wait a minute. Patient 1 has like 14 drugs that they're getting right now. Patient 2's got like 6, and all their doses are changing dynamically. We can't just blindly ask for p-values. And what's been awesome in terms of working with the regulatory system here is we get a chance to talk about this and to learn side by side and to innovate side by side. And Singapore, I'm convinced, is one of the few places in the world, if not the only place in the world, that is in a position to truly innovate trial design like it's always been intended, right? There's a lot of regulators around the world that commendably recognize that trial design has to be innovated, that the way we even assess new therapies has to be innovated, but Singapore is a place where it's already happening, right? And so that was my very long-winded way of saying that Singapore is optimally suited, right? The regulatory environment is optimally suited to adapt as we bring AI forward. I don't know if Dr. Jasmine wanted to add to that.
I can't agree more with what both Prof Dean and Dr. Daniel has mentioned. But in fact, I have a question of my own. So with all these new regulations that could be upcoming, is it going to be a boon or a bane for the AI innovators?
Dan, you go.
Dean, boom, bang.
I think it's going to be all good. I actually think it's a good thing, right? I think that it's, I think blending co-learning, co-innovation, co-advancement with eventually solidifying these into actionable regulations, that's critical, right? And I think what's cool is if we wanted to go sit with our regulators, this is probably something that could be done inside of the same week, right? And I remember I'm speaking to colleagues from around the world, and when I mentioned this, they're like, what mythical place are you talking about where you can make this happen, so quickly? Because we're talking about time scales of days to weeks, and there are places that are at time scales of months to never. Right. And so I would say, yes, I think it's great that regulations are emerging off of these very fruitful discussions that have been happening.
And this is one of the great advantage, right? I mean, to be small, right? I mean, from one end to the island to the other end, right? I mean, proximity wise, right? I mean, if you look at China and US, if you really actually are not in a metropolitan area, if you're trying to do stuff like this, you may have to take emails and stuff. Physical visits will take you days, and for all these travels and stuff. But being a small country, this is one of the unique advantage I think we have, right? I mean, so that's one thing. And,
Oh, anything to add on?
And then the SOPs, right? I mean, like what you guys said, working very closely. I mean, just to answer, the questions, and I think working very closely with regulators is only have benefits. I feel, right, because you can kind of really share with them what you are facing, and you just don't want to actually come up with something and then something gets submitted to regulators and then they'll come up with tons of different questions. Instead, you could actually choose to work alongside with them, like what Dean has just said. And I mean, the approval process, or like the time to approval process, is actually going to be much more expedited. So I mean, those are the things that I personally have reaped the benefit from working quite closely with the HSA colleagues. For Selena, for the AI DR screening tool.
Yeah, I couldn't agree more with especially the fact on the efficiency in Singapore systems. I think like I mean from this we can kind of conclude that implementation is not really a huge challenge moving forward in terms of regulation. But I think another questions that we have on the site is that then how about uptake? Since implementation from a nationwide scale isn't a problem, but how about from a more ground up approach in terms of the healthcare professionals themselves. Here we actually have a question asking whether the majority of the practitioners are actually open to learning how to use. Yeah.
Yeah,
And
I
what
mean,
yeah.
yeah, this is a great questions, right? I mean, don't get me wrong. I think adoption and implementation of AI is tough, right? I mean the things, the good examples that we share and the experience that we had. I think we just wanted to also make sure that the audience doesn't really get the wrong message as well. That adoption and implementation is really hard, right? AI is tough. I mean, we are working, very closely with the ecosystem, but like what Dean said, right? Dean actually has said multiple times, and he said that ideation to implementation is like we're talking about, the Earth and the Moon, right? So a lot of the things actually die in uh, in the journey. We call it as Valley of Death. So I mean, how do we actually minimize that? This is something that the SOPs, right, standard of practice, and the having a good consensus committee to come together and do that. I think these are some of the very important factors. And instead of in terms of the openness of the AI practitioners in Singapore globally, I can just share one of the studies that we are still in preparation for manuscripts, looking at how prepared the ophthalmologists, optometrists, in adopting AI to screen for different conditions. And to my surprise, I thought half of them were not actually too receptive to do that. But I'm quite heartened to see that actually 60 to 70% they know they have to do it. And of course, the younger the optometrists, the more receptive they are. I mean, this is some of the things that we found in the study. And it also depends on the disease that they screen. And the other big factor is related to security, right? Is this AI going to replace their job? And this is a big factor, not in ophthalmology, in medical world, or even in the non-medical world, right? For people who wants to adopt AI, first thing is the security. First, I should still keep my job, and my job needs to be more interesting. I think that's the second thing, right? And then I should I mean the AI, if it works, it should actually take away the painful stuff that I do not want to do, right? I mean those are the very simple thing. I feel AI could actually play a very good role. So I mean, going back to the questions, whether the openness, I think it really depends on the field and depends on the subject matters. Yeah. Dean and Jasmine, what do you guys think?
I was actually going to ask Dr. Jasmine. I'm very curious from the pharmacy perspective because we deal with mostly intervention on
Yeah.
our side. What the viewpoints are?
I think the pharmacy community is definitely opening up. I mean, there's been quite a lot of talks about adopting AI in our work. And that's also one of the primary reasons why I'm pretty interested in using in AI applications, especially in medication safety. So I think when we actually engage our own colleagues as stakeholders, and when we talk to them it's very important to be able to deliver a consistent level of service. And deep down inside, I think we know that all humans have limitations, and with the adoption of AI, that can potentially help us deliver this consistent service to our patients. So I think on the ground we are starting to be more and more open to the adoption of AI in our work. And okay, I do think that some people still feel that AI is going to take away their jobs, but I think I do agree with what Dr. Daniel has mentioned. It probably only takes away the mundane, routine, the very repetitive jobs that we probably don't want to do, and we can actually move on to do more complex work. And in a sense, it's kind of like redesigning our job scope as well. Yeah.
Cool.
Totally understand. Yeah.
It's like how Dean repurposed the drugs. We repurpose the job scope. Just saying.
Yeah, I think one of the biggest change that needs to happen is really the mindset shift in a sense. I think there's still quite a lot of fear when it comes to security, like what was mentioned previously. Actually, on that note, beside like the mindset and everything, is there any other challenge that you foresee, like let's say if we try to nitpick, something that you can tackle in the future in terms of making the implementation, the rollout even more efficient, or even like shorten the timeline of adoption? Yeah.
Yeah,
What?
I think like
Go
the
ahead, man.
one. Oh, sorry, Dean.
No,
Why don't you
please.
go first?
You go first.
You sure? Okay.
Yes, go for it, dude.
No, I think like one of the things that actually personally I'm actually building at the SingHealth cluster level is to build a good data curation platform, right? So basically, how do you actually streamline the data that you collect, within the healthcare system? How do you de-identify them, make sure they are safe to be used, and how do you actually arrange them in a manner such that when the AI scientists want to pull out, it doesn't take you 10,000 years to go back, curate the data, and then there's missing data. And, there's out of the 10 columns that you can only find like 5. There's a lot of time when we do AI research or, the innovation projects, a lot of time are spent on that. So those are one of the very low hanging fruits. I'm not saying that it's very easy to do, but compared to say, adoption, changing the patient's outcome, and predicting the future, that kind of thing, I think this is the bare minimum that we can actually start the AI journey on, right? Get the data right. Yeah. So I mean that is my the key point I wanted to share. Dean, sorry.
Yeah, that's absolutely correct. I think from a logistical standpoint, there are very clear marks that have to be met. I would say that thinking forward, showing that these platforms can make healthcare more accessible while generating these better outcomes at the same time is going to be important. So, it's funny. Several years ago, we started thinking about these approaches to optimize treatment. We were generally met with responses like, no, drug selection has to be purely mechanism driven. You have to give anything less than maximum tolerated dose is just wrong. Right. And I get it. Right. But pre-data, you have to kind of start somewhere to try to prove that this could work. And then I would say about 2 years ago, I met with some senior leaders from medical schools across the US. And I was explaining to them what we were doing. And then one of them, from a very prominent medical school, the number one guy spoke up, and he was like, this strategy of individualizing how you treat patients, and I'm sitting there thinking it's going to be like 10 years ago, right? It's going to start all over and say, no, this is impossible. And he was like, this actually allows us to start analyzing how we are potentially saving costs. And really looking at the economics on a per patient basis. So I was shocked, right? I actually was quickly messaging my buddies because I was shocked that, after many years, finally, right, this is happening. And so we started doing that. We started analyzing how much we were saving patients. And so we had a previous patient that I mentioned who was being warded constantly, right? And when a patient's constantly being warded, there are costs to the patient and there are costs to the healthcare system. And so we started looking at what reducing the medication would do in terms of potentially preventing rewarding as well as improving outcomes. And interestingly enough, the drug that was prescribed at the time was pretty expensive. All right. And we ended up giving the patient about half of what they thought they needed. We potentially could have given more, but the thing is, this patient constantly getting rewarded, we were afraid that the patient would just give up at one point. And so what we find is a 50% dose, this patient's getting great outcomes. right? So by the way, for this particular drug, they're paying for 50% use, right? So they're already saving a lot of money there. And they're not being rewarded, which is savings across the board to multiple parties. And then, of course, you can try to figure in, and this is actually addressing one of the questions I saw earlier in terms of affordability and accessibility. But really, to see AI implemented, there is a payer side as well, right? It has to help potentially the healthcare system spend less, the patients spend less to deliver better outcomes, right? And this even addresses a really important and heartening point that Dan mentioned at the beginning, which is the low middle income countries, right? The LMICs, right? I think we have a responsibility to ensure that when we say improving accessibility to optimize care, we don't only mean places where patients can afford, expensive medication, and even if they can't afford it, at least have access to them, right? This is so when we talk about AI making it, we have to try to think top down, right? Which is, what are the challenges we have to prove for this to even have a chance? Because if we don't think that's going to be possible, the barriers are very clear in the beginning, right? And again, and for the students who are in the audience, right? I think just by having this event is heartening, because we already see students now engaging with the stakeholders they have to engage with, and it's much better that you engage with them now while you're still in school versus 30 years into a career thinking, hey, by the way, maybe now it's time I try, right? So you're jumping in early, and I think that's outstanding and it's commendable.
Yeah. Thanks for the, I'm pretty sure our participants are even more, enthusiastic now. So actually on this note of, actually when you mentioned the different demographic, I just have this question, because when it comes to data, especially clinical trials or like, past data that was collected, we often have this idea that, most of the data will be more Western centric, in a sense that, more Caucasian data as compared to, for example, Asian data, especially the different ethnic groups in Singapore. I think, when it comes to treatment, dosage, or even some of the, pharmaco effects, there will be slight differences because of the genetic makeup. And actually, there's this question from Zoom as well that I just shown on the screen. So when it comes to, AI, machine learning, there's always, algorithms that are being making decision based on data. So in terms of the Singapore context, when it comes to different races, how can we navigate the issues surrounding ethnical specificity and then sensitivity, in the healthcare system? Yeah.
I'll try to take this because I work on a lot of the big data, imaging data and stuff. I'm not sure how many people in the audience actually read a paper from Google that has actually shocked the world, right? Retina imaging, predicting gender, predicting your age, predicting your blood pressure, right? From fundus imaging. So, I mean, those are the things that we know. The image does carry certain characteristics depending how you train them. In the AI and the technical world, we call that as AI bias, right? How do you actually rectify or even address the AI biases? This is something that is a very hot topic right now in the technical machine learning and deep learning community. How do we reduce this? How do we actually build an AI system that is reflective of the exact populations? So when we actually do the research, right, how do we usually when we do when we actually build the data sets, we would need to take this into serious account, right? Singapore majority Chinese, followed by Malay, then Indians, right? So that is the percentages of the population, and then how do you see them, right? And when you go to US FDA, CE mark, or any regulatory body, we actually the regulatory body actually will take this into account too. Is your AI system tested in the population that has has that been included in your studies? Has it been included in your trials? And is it representative, right? And the representation of population can further be divided into the population base or hospital base, because we know the prevalence rate of the disease between the two settings are completely different. One, you talk about low pre-test probability. I'm not sure how much stats do you actually go into. I'm I'm getting a bit more serious now, as you can tell, to the more technical front. but I do. I just wanted to show I do legit stuff, right? Okay. Yeah, and and all these things, it actually uh, determine how your testing data sets are being defined. So in clinical trials we talk about power calculation. Same thing for AI testing, we talk about power calculation, and all these ethnicities differences, pre-test probability between the different settings and things we all have to take into account. Yeah.
Yep, totally understand. Prof, anything to add on this note?
I just say that that's why I think from an intervention perspective, we actually strongly go with patient-specific acquisition of data, right? Because patients 1 through 10 have no bearing on patient 11. Patient 1 has no bearing on patient 2. I think that this kind of agnostic way of acquiring data in the right way ensures that we're always trying to optimize individually. Now, if we also look at approaches to develop therapeutics that are population optimized or subpopulation optimized, when that happens, again, the way we acquire the data still matters, right? And so as long as we treat this as again, I'm speaking purely for intervention, for treatment and drug development, as long as we treat this as an optimization challenge, right, that will ensure that we always are collecting data with finding the best possible treatment regimens in mind. But again, we may have to adapt that according to whether it's a specific strain of a pathogen, whether it's a specific type of cancer that is specific towards a specific population, all of the above. But this just further proves that how we acquire the data, not just based purely on volume of data, will play a big role in determining how we use AI for treatment development.
And I just wanted to add, right, the biases also doesn't just depend on the ratio, and also the settings, and the biases is also sometimes is highly relevant to the certain practice patterns, right, of certain countries. Some countries actually protocolize a treatment based on the health economics or the accessibility of the medications and stuff, and this is another type of bias that we actually talk about. And I'm sure, like Jasmine, actually you do see a lot of the biases like this as well. So yeah, what do you think?
Yeah, so this is a very interesting question because just a couple of weeks ago, I was working on a project looking at whether I can predict medication adherence in some of my in my population of patients. And one interesting question that someone asked was, are you going to use patient demographics data? Are you going to use financial information, whether the patient is on Medifund, whether the patient is whether the patient is receiving some kind of financial support from the government? And so that actually I think that tied in very well with the question that was asked. So very importantly, I think it's the data that you choose to input into your algorithm. So as I was mulling over this question, I was just doing some of my own readings, and I came across this article talking about how some of the US hospitals, when they actually adopted an AI algorithm to predict which patients could receive a referral to a specialist care, they found that actually that algorithm did not refer a lot of the African American patients into for higher care when they're equally when they're really even when they're very sick and almost as sick as their Caucasian counterparts. And that, I think, that basically just highlights how we need to be very cognizant of the type of data that we put in. So it turns out that actually the algorithm was feeding off I think healthcare spending data. So it's just for the fact that the African Americans don't have sufficient exposure or are not able to actually utilize healthcare. I'll have very low healthcare spendings, not because they're not sick, but just because they're not able to. And so the algorithm is kind of biased against them in this population. So this is actually quite an interesting, question that came up, because this is really very relevant to what I was working on previously. Yeah.
There's also, I'm not sure whether you guys read this, but there's also a AI bias in terms of like in the banking industry where they actually wanted to create the lines for men versus females, and and apparently because of the AI bias, they actually created a more lanes for men than female, and that get like a really that actually had a really bad backslash on that. It shows that it's just from the certain data sets that they actually acquire the data from. We can't emphasize how important the data that you are actually building on and testing on, because that would actually inject a lot of bias. So I mean, this is a great questions, and this is all the AI designers, all we are constantly thinking about. Yeah.
Yeah, totally agree. I think like at the end of the day, it's also about how we can minimize the amount of data that's collected and yet maximize the output and the benefits. I think that's what I've gathered from all the sharing thus far. I am conscious of the time. It's 9:05 now. Perhaps I just open it up to all our participants in both AirMeet as well as on Zoom. If you have any questions, feel free to send them in. If not, I actually have a follow-up question when it comes to data. I think another question or topic that a lot of people will talk about is privacy. So on that note, when it comes to adoption and usage of AI and all this technology in healthcare, is there a specific stakeholder or like a major stakeholder that should be responsible when it comes to upkeeping the privacy of such data? And perhaps you can start with this question. Yeah.
I'm defaulting to either Dr. Dan or Dr. Jasmine on this one.
I'm defaulting to Dr. Daniel.
All right, it's a majority. It's a majority.
I was about to suggest Jasmine to do it because
Too late.
She's recently doing that.
Too late.
Applying for IRB
it.
No, I think like Drew was like, I think the data governance in any healthcare institution is governed usually by the ethics, the committees. So usually they will when you submit your ethics, submit for ethics approval, you actually do need to satisfy a few things, right? How do you keep the data, right? I mean, as simple as that. Are you going to keep it just any thumb drive, or is the thumb drive going to be encrypted? Is it going to park in the cloud? If this cloud, where is the cloud going to be hosted? Is it locally, internationally, right? Because you need to make sure that your data actually stays within your country, outside your countries. Some actually mandated the data actually to stay within your hospital institution within your country, right? So those are the one thing about data storage and data, the governance, right? That's the one part. Second is how do you de-identify the data, right? I mean, how much to de-identify? What is data de-identification and what is called data anonymization? They both carry different meanings, right? And those are the few different things. I mean, top two things that you have to be very careful about. Those are the two things. And each hospital institution will have the chief medical informatics officers, CIMOs. They will have ethic committees. They will have a research office. So those are the things that you have to pass through, during the R&D phase. When you come to deployment, same thing, right? I mean, it really depending on whether you need the patient's identifier to actually run the AI software. If you don't actually usually we try to actually not include that as part of the AI analysis, just to really make sure that we don't actually have to handle too many of the unnecessary data governance related stuff. I mean, ultimately, we just need to make sure that the data is being kept safe and to benefit the patients. Yeah. Dean and Justin, do you guys have anything to add? Yeah.
I was going to say, I mean, I think that there are both substantial but continually evolving ways to assure that proper governance and stewardship of the data is being accounted for. I certainly don't think there should be fear of allowing data to be used for patient benefit, right? But I certainly think that there will need to be continued evolution in how we assure the safety of and the safeguarding of this information, which is why things like blockchain coming into play, which Dan and others are starting to work on as well. I think there's a lot more room to create a better and secure bridge between the storage and management of data and actual intervention or diagnostics with it. But that in and of itself is a field, right? So, and that field's going to continue to grow.
Yep. Okay. Yep. Thanks. I think that totally answered my question as well. In regards to privacy and everything surrounding the implementation of AI. It doesn't seem like we have any more questions from the floor. Perhaps I think it's a long Monday for most of us here. We can always close this session slightly earlier. If for the next few minutes we don't really have any further questions. Perhaps to the panelists. Since we are talking about how this hackathon is really organized by the student for the students, and see how we can really kickstart this journey slightly earlier instead of having regrets further down the road. Is there any how would you summarize? We have talked a lot for tonight already. Summarize tonight's topic, ethic and AI in healthcare in a single sentence. It can be about the future, can about about your sentiment, anything at all.
I think ladies first this time. I'm gonna speak first so that I can get the arrow pointed to somebody.
I think I want to say it's an evolving field. I think, I myself, I'm new in this area, and I'm excited to see what the potential is for AI in healthcare, especially in the field of pharmacy and medication use. And I think this entire forum, this entire Beyond Health health hack is really good. I think I'm very inspired and encouraged by the students and the work that they are putting in to try to get this up and going. And I think I am feeding off the energy that the youngsters are actually bringing. Yeah.
Thank you. How about Prof Dean next? Seems like Dr. Daniel was shooting the arrow.
I'll just add that.
Ethan, you're learning very fast.
There you go.
Very good.
I'll add that stepping outside of the comfort zone is essential for making substantial advances in a field, right? So I think that as everybody embarks on or continues on their studies, it's great that everybody's making time to engage with somebody else in the field who potentially works in something totally different, because it is inevitable as we bridge ideation with deployment that there will need to be a lot of interdisciplinary huddling and collaboration, and when minds from different fields huddle together, great things can happen, right? And the deeper these conversations are, the greater the greater the things that can happen. The final thing I'll say is empathy, right? Empathy, interdisciplinary empathy. And what I mean by that is, I think when different fields initially started to collaborate, say decades ago, a lot of it was, hey, I'll do my thing, you do your thing, right? If it's a clinician going to an engineer saying, hey, look, I've got an idea, can you make this for me? Right? Or if it's an engineer going to a doctor, I've already made this thing, can you use it? Right? I think that interdisciplinary empathy, in terms of better understanding what the different fields bring to the table, the challenges of the different field, opportunities of these different fields, the earlier we make the effort to try to bridge that and to understand other fields earlier on, I think it seeds what will ultimately be successful innovation faster, right? So I think for the students out there, we're all in a multidisciplinary ecosystem already, and the fact that we're in this event where we have all kinds of disciplines talking to each other. Collaboration is one thing, but then really making the effort to understand opportunities, challenges between the different segments of this continuum will really be catalytic to changing healthcare. So kudos to the students for having this event, and kudos for the continued conversations you're going to have outside of your own discipline. I think it's going to be an exciting time.
Yeah, I think Dean, I think you summarized it really well. And Jasmine, I think I was just joking with Jasmine that after today, I hope that I should get a large pool of fans, from our own school or pharmacies and stuff. I really do hope, you guys could follow your 大姐, right? 大姐, right? To actually follow her footpath.
So review my age.
Tajie can always be just 1-2 years older. Yeah, but I just wanted to add, right? I just want to encourage everyone here. I think sky is the limit for innovation. Never fear to dream, right? I think if you dare to dream, I think you're making your first step, right? Of course, you cannot just dream, right? You need to do some real work, and and I always like this quote, right? I use it in multiple platforms. Eyes on the stars, feet on the ground. I usually will ask the audience who's the quote by, but this is someone. This is a quote from the Roosevelt, right? So there's a long. Uh, I I really feel that you have to really work hard for your dream, right? I mean, never fear to also fail, because I mean, in innovation, you'll fail more than you succeed, and you feel you learn your lesson and do a better job next time. So and keep it fun and really enjoy and have fun. I think having fun to me is really, that's why I may seem to be joking all the time and stuff. I didn't put out I didn't put on my operational like the face here, but because I feel that innovation should be fun, but when you need to actually get the real work done, you need to be serious. So just choose the time properly, and most importantly, get Professor Dean Ho's email address, Dr. Jasmine's email address, Dr. Daniel Ting. Yeah, sure, right. If you want to go out for a drink, yeah, sure, no problem. Yeah. So I think do reach out, and then don't just come into the channel. Oh, I feel so inspired. The next thing you go to bed, and next day the life just carry on. Don't do that, right? Think of one thing you want to change, and start from there. Yeah, start small, but make it work. Yeah.
Wow.
Very
Yeah,
inspiring.
very inspiring
I'm
indeed.
inspired, man.
Couldn't
Okay,
agree
let's go
more.
out for a drink.
There you go.
Yeah. So yeah, I think I'm not seeing any other questions streaming in. So in that case, we can close this session slightly earlier. I just want to say thank you once again to all our panelists. I think the session was both, insightful and inspiring, and also like I think Dr. Daniel really, lighten up the mood as well. So I hope everyone who tuned in tonight enjoyed as much as I did. I definitely learned a lot as well. So maybe you can just give another round of applause for our panelists and just spam the clap emojis and anything. Yeah. If not, I'll just end off the session right here. Just everyone, thank you for joining us and have a good rest tonight.
All
Thank
right, see you
you.
guys.
Thanks for having me.
Thanks, everybody. Thanks again.
Thank you.